to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, where I'm also the Chief of Pediatric Cardiology. Thank you very much for joining me for this 293rd episode of the podcast. I hope all enjoyed last week's episode on the topic of 22q11 deletion syndrome, in which we spoke with Dr. Lindsay Freud of the University of Toronto. For those of you with an interest in fetal cardiology and genetics of cardiology, I'd certainly recommend you take a listen to last week's episode, 292. As I say every week, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week we move into the world of adult congenital heart disease, and the title of the work we'll be reviewing is Effect of Sodium Glucose Cotransporter 2 Inhibitors in Adults with Congenital Heart Disease. The first author of this work is Ralph Nijenhuis, and the senior authors are Grushin Veltman and Anastasia Egorova. The first author, Dr. Nijenhuis and Dr. Egorova, come to us from Leiden University, and Dr. Veltman comes to us from the Scottish Adult Congenital Cardiac Service in Glasgow, Scotland. When we're done reviewing this paper, Dr. Egorova has kindly agreed to speak with us about it. Therefore, let's move straight on to this interesting article and then a conversation with one of its authors. This week's work begins with a number of comments about the fact that heart failure is the most important cause of morbidity and mortality in the ACHD population, with a 5 times enhanced risk of dying versus those ACHD patients who do not have heart failure. As we all know, however, the ACHD patient population is very heterogeneous. And so heart failure in this patient group can be due to many different factors in addition to all the usual ones like coronary artery disease or hypertension that can plague any adult. The authors explain that though there are guideline-directed treatments for heart failure in the regular standard heart failure adult patient, there really are none for the ACHD patient. The authors then speak about sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitor agents, and explain that this relatively new class of drugs have been shown to reduce the risk of heart failure worsening, as well as reducing cardiovascular risk of death in the adult with conventional heart failure, and they describe them as, quote, a pillar in the treatment of heart failure. They then explain that it is not known precisely why these agents have such an impact on heart failure patients, and remind that the agents are known to have some direct hemodynamic effects that promote diuresis and natriuresis, but also seem to improve cardiac function by reducing sympathetic nervous system overactivation, and also reducing pressure overload-induced myocardial fibrosis, decreases in inflammation, and also generally improve overall myocardial function and energetics. Despite all these potential positive impacts, the evidence for its use in adult congenital heart patient-induced heart failure is lacking. However, as is the case in most congenital heart disease management, practitioners are starting to increasingly use these agents in the ACHD world in an off-label manner, and so the aim of this study was to study the patterns of its use, the safety and tolerability of the agents, and also to look secondarily at efficacy in short-term heart failure management in this complex patient group. The study was conducted internationally at 4 centers in the UK and Leiden in the Netherlands, and was retrospective in nature. All patients with ACHD greater than or equal to 18 years of age who were initiated on one of these agents between April 2016 and July 2023 were included. Data collected from 1 year before initiation of the SGLT2 inhibitor agent and at each subsequent outpatient visit until the most recent follow-up were included. For this work, the primary outcome was safety and tolerability of these agents in the ACHD population. Secondary outcomes assessed included its efficacy as a heart failure medication, and the principal way they assessed this was by the occurrence of a hospitalization for heart failure and a comparison of the rates of hospitalization for heart failure prior to the agent and after. Another secondary outcome measure was admission for arrhythmia or changes in concomitant heart failure medications. And on to the results. In total, there were 174 patients in this work at the 4 centers, and the mean age was nearly 49 years, and 41% of the patients were female, and 29, or 16.7%, had type 2 diabetes. The median systolic and diastolic pressures were 113 and 68 respectively. About 6% had mild congenital heart disease, with 43% having moderate and 51% severe forms of congenital heart disease, with 93% or the vast majority having 2 ventricle congenital heart disease, and 7% or 12 having a single ventricle. 4% of the patients were cyanotic with a SAT of less than 90% at rest. The median follow-up in this work was 7.7 months, and 4 patients, or 2.3%, died in follow-up, with death caused by heart failure in 1, sudden death in 1, a respiratory infection in 1, and GI bleeding due to warfarin in 1. And so what were some of the main findings? First and importantly, if you look at Figure 1 on page 1406, you see clearly that these agents were markedly more commonly prescribed in the past 2 years than the early years of this study, with 79% started on dapagliflozin, or Farxiga, and 21% started on empagliflozin, or Jardiance. Heart failure was the most common indication for these agents' use in 93%, followed by type 2 diabetes in 6.3%, and chronic kidney disease in 1 patient. And so regarding the primary outcome, which was tolerability and side effects, what were the outcomes? Well, side effects were seen in 18 patients, or about 10%, with 9 patients requiring that the agent be stopped, at least temporarily, and in total, amongst the whole group, 6.9%, or 12 patients, had it permanently stopped due to a side effect. And Table 3 on page 1408 basically shows that orthostatic hypotension occurred in 6 patients, UTI was seen in 5, rash in 3, fatigue in 2, dysuria in 1, and frighteningly, 1 patient developed Fournier's gangrene. The authors go over the patient's weight and electrolytes, and they were basically unchanged in the first 3 months. And though diastolic blood pressure did not change, systolic blood pressure fell from 113 millimeters of mercury to 108 millimeters of mercury. And there was also a similar bump in creatinine from 0.8 to 0.9, and both of these changes were statistically significant. And what about the most important secondary finding or question, which was related to heart failure admissions? Well, it turns out that there was a significant reduction in heart failure hospitalization rate when comparing the 6 months prior to and then the 6 months after starting these agents, with a relative rate of 0.30, or a roughly 3-fold reduction in hospitalization in the first 6 months when treated with these medications. And what about arrhythmia admissions? There was no significant difference in this when comparing admission rates in the 6 months prior to and after initiation of these agents, and these points are clearly shown in the central illustration, which is found on page 1412. In their discussion, the authors state, and I quote, "The main findings of this study are that 1. Despite limited evidence, SGLT2I are prescribed with increased frequency in the heterogeneous ACHD population, with heart failure as the most frequently encountered indication. 2. These agents are safe and generally well tolerated, with comparable occurrence of side effects to the landmark trials in conventional heart failure patients. And 3. These agents' use was associated with a decreased 6-month heart failure-related hospitalization rate, suggesting a potential prognostic benefit for patients with ACHD and heart failure." The authors review how there was a steady increase in the use of these agents over the study period, and they contrast it to the prior U.S. studies showing much lower usage in this patient population of ACHD patients with heart failure, with most of its use in the U.S. used for the initial rationale for its existence, which is as a type 2 diabetes therapy, and they wonder if the higher amounts of type 2 diabetes in the United States may partially explain why this was the indication more commonly in the U.S. The authors remind that an aggressive management scheme of heart failure treatment was used, with more than 80% of the patients using an ACE inhibitor, an ARB, or an angiotensin receptor neprilysin inhibitor in combination, and 45% having one of these agents in combination with a beta blocker on top of the SGLT2I agent. They reference other smaller studies in which these agents were used in those who have systemic RVs with good impact on heart failure hospitalization, and wonder if this may signal that the agents are actually useful for patients who have RV failure. The authors re-emphasize that the safety was generally good, with good tolerance of these agents similar to other adult groups that take these medications, and they review the case of the single patient who developed Fournier's gangrene and why this may have occurred. They speak about the substantial reduction in hospitalization in this study, and how hospitalization for heart failure in the ACHD patient is a risk factor for death, and so the 3-fold reduction in hospitalization in these patients may in fact be quite meaningful in regards to a potential impact on survival. In regards to limitations, the authors speak of the clinical retrospective nature of this work and how doctors started this therapy at the discretion of the physician who was treating, possibly introducing bias. They also mention the lack of a standardized follow-up protocol, the profound heterogeneity of these patients, and how even this relatively largish group is still small given the differences between patients and the overrepresentation of complex disease, disallowing meaningful conclusions about less affected patients with milder forms of congenital heart disease. They feel that the work has, to use their words, provided a strong foundation to justify a prospective randomized trial to better understand the impact of these agents on ACHD heart failure, and also to better understand the mechanism of their benefit. And so they conclude, this study is the largest to date to evaluate the use of SGLT2 inhibitors in the ACHD population. These agents were well tolerated and safe in 174 patients with ACHD, with similar side effects and treatment discontinuation rates to the SGLT2 inhibitor trials in conventional heart failure patients. In 162 patients who received these agents for heart failure, these agents were associated with a threefold reduction in heart failure hospitalization rate during follow-up compared to before treatment. These positive results might indicate a prognostic benefit and warrant further prospective randomized investigation of the potential benefits of SGLT2 inhibitors for ACHD-related heart failure. Well, this is certainly an interesting work, offering us a glimpse into a possible new therapy for treatment of this growing patient population of ACHD patients who have heart failure. As the authors have explained to us, heart failure is the number one problem that our ACHD patients ultimately develop, and it is the most common cause of death amongst this patient group. And so finding novel therapies to reduce hospitalization may very well be extremely important. Understanding how these agents are working for these patients might be very helpful in better understanding how we can tailor their use to the patients. There's a paucity of single ventricle data in this work, and I think all of us are particularly worried about this patient group, in addition to the systemic RV patients, of which there are also many. I'm guessing that catheterizing these RV patients may prove to be very helpful, given our limitations with non-invasive assessment of things like RV diastolic function. For sure, it's hard to disagree with the author's comments about the importance of future trials to better understand the safety, efficacy, and mechanism of effect of these agents. In the interest of time, I think we should move forward to our conversation with one of the work's senior authors, Dr. Egorova. Joining us now to discuss this week's work is its senior author, Dr. Anastasia Egorova. Dr. Egorova is an adult congenital heart disease cardiologist, as well as an expert in cardiac implantable devices, and she works at the Heart-Lung Center at Leiden University. Dr. Egorova is a cum laude graduate of Leiden University for medical school, and she completed her PhD at the same institution. She also completed her cardiology training at Leiden. It is a delight to welcome her to the podcast all the way from Leiden. Welcome, Dr. Egorova. I'm here now with Dr. Anastasia Egorova. Dr. Egorova, thank you very much for joining us this week on the podcast.
Thank you very much for inviting me. It's a pleasure to be here.
Great pleasure to have you. It's amazing to have an author of such a prominent paper on. Very excited. Dr. Egorova, many of the listeners of this podcast are pediatric cardiologists in whom sodium glucose transporter 2 inhibitors are really uncommonly used. I'm wondering if you could explain or describe for the audience what the agents were first described for, and maybe some general information about how they're believed to improve heart failure outcomes and evidence for their use in the non-ACHD patient.
Yes, thank you very much. Well, so that's an excellent question to kick off with. So the sodium glucose Cotransporter 2 inhibitors, SGLT2 inhibitors for short, actually were introduced into sort of the pharma applications as an anti-diabetic drug. So they're a class of medications that block the sodium glucose transport proteins located in the nephrons of the kidney. And by that, they actually inhibit the active resorption of glucose in the kidney and therefore lower blood sugar. They were first marketed as a drug for type 2 diabetes, but very soon it became evident that actually these drugs also have very potential diuretic and natriuretic effects, directly impacting the hemodynamics of many type 2 diabetes patients, which concomitantly had heart failure. So by now, SGLT2 inhibitors are approved for heart failure across all ranges of ejection fraction. So as in Europe, we like to think of it, HFrEF with a reduced ejection fraction, the mid-range, and the preserved ejection fraction. They hold a class 1 evidence for prescribing them according to the current guidelines. Their mechanisms of... Yes, I'm sorry?
No, please proceed. I'm sorry.
Sorry. So their mechanisms of actions are still a little bit mysterious to many of us, as they seem to be very multipotent. And obviously, like I mentioned, the direct hemodynamic effects on diuresis and natriuresis seem to be the more straightforward effects in heart failure. However, there's a large mystery as to how these drugs actually reduce myocardial fibrosis, interstitial fibrosis that is so commonly encountered in more of the advanced heart failure patients. But they also decrease inflammation. They decrease that on endothelial level, but likely also on the level of pulmonary vasculature, and a few studies will allude to that, I think, in the near future. And we really don't know what interaction of these mechanisms it is, and whether it's the sympathetic nervous system activation that they manage to hold, whether it's the myocardial fibrosis of anti-inflammatory options. But we know that in the end, they really improve the myocardial energetics and favor the cardiac remodeling in a positive sense. So they've really been a game changer in the adult heart failure field.
Well, thank you very much. That was a great description, explanation for our know-nothing pediatric cardiologist, of which I am a card-carrying member of that group. So, Dr. Egorova, side effects and the development of these was the primary outcome for your work. Can you describe what the most common side effects are in patients who are taking this agent, and amongst the side effect possibilities, which were you most concerned could occur in the adult congenital patient group in which you used the agent, and was this actually borne out by your results?
Yes, thank you very much. So we looked at 174 patients who were initiated on SGLT2 inhibition in the context of ACHD-related heart failure. And actually, in the vast majority of patients, heart failure was the primary indication to start SGLT2 inhibition, and type 2 diabetes in about 7%, and renal failure in really just a few patients. And I think for us, one of the main concerns was, of course, orthostatic or any other form of symptomatic hypotension in a relatively young patient group who had systolic blood pressure or a mean value of 113 and a diastolic blood pressure around 68. So these were not your classical hypertensive cardiomyopathy patients that we often encounter at the older age. Yes. And of interest, only the minority of patients actually experienced orthostatic hypotension, and it was really the reason to discontinue the drug in just a few. And this was really, I think, a vast surprise to us as to how well these patients tolerated this drug. So 3.4% experienced hypertension. There were a few patients that had, 3 patients that had a rash, which amounted to just under 2% of the study population. The dysuria and urinary tract infections, which I think are factors that we're always a little bit concerned about, although some of that has now been justified, I think, by the more recent studies. But where patients are having glucose that they're losing through their urinary tract, you're obviously very concerned for urinary tract infections. And they occurred in about 2.9 to 3% of the patients in the study. So overall, the data in adult congenital heart disease patients really was in line with the large landmark trials, including hundreds and thousands of conventional heart failure patients. And this was a very reassuring finding to us that we weren't surprised by any shocking side effects that we that we're typically afraid of in this patient group, and that they tolerated this drug quite well despite relatively low blood pressures at baseline.
And Dr. Egorova, the reason that patients get UTIs, that has to do with the high content of glucose in their urine? Am I understanding that right?
Yes, so this is quite a matter of discussion, and we actually spoke to some folks from the AstraZeneca, which is the company that produces dapagliflozin, which was the drug that we prescribed most frequently in this patient group in Europe. And they actually were not quite sure, but there does seem to be something with the microbial flora and the metabolism of the cell lining the urinary tract. And I think one of the main sort of reflexes that we would have as clinicians is if a patient has a urinary tract infection, whether bacterial or mycotic, we would want to stop the drug. And what we've learned now from conventional heart failure patients is actually this stopping and restarting SGLT2 inhibitors is probably more negative for the floral and metabolic adaptations of the epithelial lining of the urinary tract than just continuing the SGLT2 inhibitors past the first or even the second urinary tract infection, because there does seem to be some intrinsic adaptation mechanism that would reduce the overall risk of these infections in the long term. So this is something that was quite novel to me, as intrinsically we would, I think, as medical professionals, stop a certain drug if we really believe it correlates with the side effects.
I see. Very interesting. Thank you for clarifying that. I'm wondering, is there anything particularly special that you do in monitoring a patient who's on one of these agents different than you would for any patient in whom you have heart failure?
To be honest, not. So when we started off, we were very cautious and we had intensive contacts with the patients, and we had a substantial portion of them who we sent off home with all sorts of digital home monitoring tools, which, a weight scale and a blood pressure monitor. Some of them linked through various apps to our hospital system, just to make sure that if there are severe cases of real hypertensive dips, we would be able to identify them early. And actually, as a matter of practice, we were really surprised as to how little, extra information and extra events we detected in that way. So now we start them off just like a regular heart failure patient. We would be starting off and titrating on heart failure medication.
One of the things I found interesting was, or I should say was absent, was the single ventricle. It was a very small percentage of your particular cohort. Obviously, this is a growing population of patients. I often say it's the tsunami that's coming towards us. Do you think that these agents will be helpful in management of this patient group? Is there any evidence for their use in the single ventricle patient?
So thank you very much for raising this, I think, very important point, because also on this, on this side of the ocean, this also is, I think, a major concern, and we are seeing increasing numbers of patients with this Fontaine's circulative syndrome, to keep it as a broad term, which of course may be very, very multifactorial. We only had 9 Fontaine patients in this registry, and we know we have about 20 that have started this drug to date. And I think what's very important is that we don't fully understand the mechanisms involved in this Fontaine's circulatory syndrome. There's probably a portion of these patients who have diastolic dysfunction. There will be some that will have dominant systolic dysfunction and even AV valve regurgitation. And of course, there will be some patients failing due to a high pulmonary vascular resistance. What I think is in our highly heterogeneous, handful cohort of Fontaine patients, what I think really surprised us is how well they tolerated the drug, and also the degree of clinical improvement. And obviously, these are just cases. This is in no way a cohort study of Fontaine patients. But I think the multifactorial working mechanisms of these SGLT2 inhibitors to do so much more than just RAS system inhibition might actually provide us with insights as to what happens in Fontaine's circulatory syndrome, because very often these patients perform much worse than we would expect based on the systolic or the diastolic function alone. So there seems to be this heart failure-related phenomenon, probably also in part mediated by the autonomic nervous system and the general pro-inflammatory state that these patients go into. And I'm hopeful. I'm very reluctant to draw any hard conclusions in this regard. And I think the study, the randomized trial that's being started by colleagues from Toronto, will hopefully provide us with some of the answers to this question. But we do have hope that we have found a drug that might help modify the course of the failing Fontaine syndrome, and even if it's just a bridge to a more long-term solution that these patients will ultimately require.
Thank you for that. Very interesting. Well, for those in the audience, Dr. Egorova informed me that she's actually in the middle of her travels, and she was so nice to speak with us. I don't know if you're in an airport or on your way to an airport, so I'm going to finish up with this last question. Given your experience and the results of this study that you've conducted, I'm wondering what role you think these agents play in the management of the adult congenital heart failure patient at the present time. I'm wondering if you might also speak to the regular guideline-directed heart failure management of the adult non-ACHD patient and how your team is adapting the guidelines to the ACHD patient, and and what role you think these agents are going to play in the future.
Yeah, so this is a bit of a tough question because, of course, we have guidelines, and guidelines require a certain level of evidence and robust studies, generally relying on prospective randomized studies, and we don't have that. And I think one of the main concerns is that I really feel that we've missed the opportunity for some of these trials because SGLT2 inhibitors are, going out of patent within the next few years. So the pharma companies are very reluctant to co-fund any of these trials. So we're going to have to generate evidence, I think, as we've historically often done in ACHD groups. And we're going to probably have to do this as clinical scientists on our own without too much expectations of external funding and the large trials with hundreds of patients. Yeah. I do think that this, we have opened up a perspective in which, this class of drugs seems to really impact the clinical course of heart failure in these patients, severely reducing their hospitalization rates. And if we can validate this in a prospective fashion and in a larger patient cohort, because we must recognize that we have started with the sickest patients in the current publication. I mean, these were really the sort of back against the wall patients who, in the course of their heart failure, were started on an off-label drug by the treating team. So we do have to validate this in a prospective setting in a larger cohort, but I am hopeful that this will impact, the management of heart failure in these patients. And we, in our center and, in the participating sites, have been prescribing these drugs in an increasing fashion over the past years. So I think this is a trend we will see continuing.
Well, very promising work indeed, and maybe the start of something, a novel way of helping our adult congenital patients in whom heart failure is such an important problem. Dr. Egorova, I want to congratulate you and all of your co-investigators, and I want to thank you so very much for joining us all the way to speak with us this morning.
Yes, thank you very much. It was a pleasure. Thank you for your time.
Pleasure. Thank you. I first would like to apologize for that annoying buzzing noise that was overlaying the first third of this interview this week as a large truck pulled up right in front of my building in the early AM hours, precisely as this interview was about to start. I guess you now all understand how it's like to live in an apartment in Manhattan on the Upper West Side of New York City. For this, I'm most sorry. I think you'll agree that Dr. Egorova was quite clear in her thoughts about this new agent class and the role that they may play. And I think her comments about the need for more prospective data to be very important, especially for the patients suffering from what she termed Fontan circulatory syndrome. Though these data are certainly very interesting and compelling, I think I share her belief that more information about their role in the ACHD heart failure patient will be needed in order to best understand their role in management of this very complex patient group. Once more, I'd like to thank Dr. Egorova for finding time between connecting flights in Europe to speak with us this morning. To conclude this 293rd episode of Pediheart, we hear an interesting recording of a remarkable event from 1985, when the great Russian basso Mark Rysin gave a performance of Prince Gremin's aria from Tchaikovsky's Eugene Onegin at a celebration of his 90th birthday. Mr. Rysin was a Soviet operatic basso for many decades, but during the Cold War years, meaning that most of his performances and recordings were made in Russia with very little international travel. Mr. Rysin was also Jewish, which resulted in a tremendous amount of anti-Semitism, disallowing him in Soviet Russia from traveling beyond the borders of the country to support an international career. For those unfamiliar, it is extremely rare for any opera singer to be singing on stage much beyond the age of 70. And for a basso to be singing at 90 is nothing short of remarkable. And so though some of the low notes may suffer in comparison to his own spectacular younger self, Rysin still sings remarkably well in this aria, in which Prince Gremin sings of how profoundly happy he is and in love with his now wife, Tatiana. Thank you for joining me for this 293rd episode, and thanks to our guest. I hope all have a wonderful week ahead.
Порывы благотворны едва увидевшему свет, и закаленному судьбой бойцу с седою головой. Онегин я скрывать не стану, безумно я люблю Татьяну. Тоскливо жизнь моя текла, она явилась и зажгла, как солнце луч среди ненастья, мне жизнь и молодость, да, молодость и счастье. Среди лукавых, малодушных, шальных, балованных детей, злодеев и смешных, и скучных, тупых, привязчивых судей, среди кокеток богомольных, среди холопьев добровольных, среди вседневных модных сцен, учтивых, ласковых измен, среди холодных приговоров, жестокосердной суеты, среди досадной пустоты, расчетов дур и разговоров. Она блистает, как звезда во мраке ночи, в небе чистом, и в ней является всегда. Сияние ангела, сияние ангела лучисто. Любви все возрасты покорны, ее порывы благотворны, и юноше в расцвете лет, едва увидевшему свет, и закаленному судьбой бойцу с седою головой. Онегин я скрывать не стану, безумно я люблю Татьяну. Тоскливо жизнь моя текла, она явилась и зажгла, как солнце луч среди ненастья, и жизнь, и молодость, да, молодость и счастье.